ourselves. We prefer names over numbers. We will give it about another minute for people to hop on. Typically start around 12:17. And again, welcome everyone.
I wonder if the person who appears as a 253 number, are you able to share your actual name and I can rename you? If you're speaking, you're muted.
Okay, Allison, anyone else coming in right now? So
I'm having trouble switching names. I haven't been on Zoom in quite some time. It's P262123.
Oh, I see you. And what is your actual name? And I'll change it for you.
Thank you. I appreciate it. Vicky Craig, V-I-C-K-I. Space Craig, like the boy's name.
Okay,
C-R-A-I-G.
V-I-C-K-I. Okay.
thank you.
You bet.
So I'm going to go ahead and share my screen and get started. Okay, once again, welcome everyone to Echo Dementia for September 22nd. If this is your first time with us, we'd love to know who you are. And we appreciate everyone who can use their video to have their video on. Today we have a didactic presentation by our own Dr. Kristoffer Rhoads, and then Nicole Kane is going to do our case presentation. So we appreciate that. Some Zoom reminders: please rename yourself, your first name, last name, and where you are. And please mute your microphone when you're not speaking. And then as you unmute, please identify yourself. Again, please turn your video on. We love to see you. And if there are several people in the same room on the call, please list your names in the chat so we know everyone who's here. Just some upcoming CME offerings on traumatic brain injury, psychiatry and addictions, and the telebehavioral health training series. Also, some resources on pain management support from Washington State for Washington State healthcare providers. Resources there. And Project Echo reminders. Remember, we don't divulge any private health information. Don't forget, all these sessions are recorded and are available on our website. And really important to us, please complete the 1-minute post-session survey. The Dementia Friends rack cards, a great resource, are available. If you need some, just put your name in the chat and we'll arrange to get those sent to you. And our upcoming Echo Didactics for the rest of this year are listed here. Your cases that you share with us are a vital part of our community, and no case is too simple or too complex. So please reach out to Allison if you have a case that you'd like to present. We appreciate it. Thank you. The University of Washington School of Medicine is accredited for continuing medical education. 1.25 credits are available for each of these sessions. And there are no disclosures today, no financial relationships to disclose. And here's your hub team ready to help you in any way we can. So feel free to call on us. And here's our footprint across Washington and even into Oregon. So we appreciate all the participation across the state. And finally, drum roll, our own Dr. Kristoffer Rhoads, an ECHO co-lead and neuropsychologist, an associate professor at the University of Washington, is doing our didactic today. And Chris is going to be talking about decision-making capacity in dementia. So Chris, over to you.
Thank you so much. And I'm wondering how I sound. I'm getting a notice that my connection's a little unstable. I sound okay. I may turn my video off while I share my slides, just so it doesn't get glitchy. I have a rare instance of working from home today. So I'll do that. And then let me share my slides. So, and thank you, Mimi, for the introduction. And thank you for facilitating today's session. It's such a pleasure to have you do that. All right. So I want to acknowledge that this is an extraordinarily difficult topic to address in 15 to 20 minutes. And I really am going to just hit the highlights. I also want to acknowledge that these are high stakes kinds of topics, like many of the things that we talk about. But I really conceptualize this as interacting with people's rights in a very big way. So I don't really have any disclosures, although I saw somebody disclose this recently. I thought maybe I should. I do maintain a very small private practice in forensic neuropsychology. Most of that these days involves capacity evaluations, although some other things as well. But I do capacity evaluations as part of my work at Harborview as well. I want to make a couple of important distinctions. Sometimes the word capacity gets confused with or conflated with competency. And really, this is more of a civil matter and a clinical matter. I think typically within the medical world, we think about things as capacities versus competency. And there are a variety of different capacities. So everything from consenting to treatment or research to driving. There are multiple types of financial capacity. And it's really, I think you will hear this from anybody that does this work, is it's really driven by the decision that needs to be made. So often there's this, request for a capacity evaluation that is global in nature, and that's really not super appropriate. The other thing that I would say is, somebody could have capacity or lack capacity, and that doesn't necessarily correlate whether or not they'll be found competent if there is some kind of a legal action, or that's part of what driving the evaluation. So the other thing I want to mention too is that competency is an all or nothing construct. So you either have it or you don't. Whereas capacity is really more of a threshold issue, and it depends on the decision or the issue at hand. So if we think about financial capacity, there are differences between testamentary capacity, gifting capacity, even, and kind of the legal standards of that. Similarly, with medical decision making, there are different thresholds depending on the complexity of the decision that needs to be made. The other thing I wanted to point out here is that capacity can be undermined by a couple of things. Sometimes it's cognitive, but sometimes it's more functional, physical, or instrumental. So for instance, somebody who has hemiplegia and can't endorse checks or sign paperwork, but has the cognitive abilities to understand those decisions. So there's kind of different things to assess here. Just touching very, very briefly on testamentary capacity. So this really is driven by a different set of rules and guidelines than medical decision making, which we'll spend most of our time on. But the main criteria that apply here in the state of Washington are understanding kind of one's bounty, who benefits from that, what's the distribution of those things, and how those things relate to form a reasonable and ideally consistent plan. And I'm only mentioning this because sometimes providers are asked to weigh in on testamentary capacity and will apply the criteria for medical decision-making capacity, which are very different. And I can think of a case about 2 years ago where the retained experts misapplication of those capacity evaluation criteria kind of blew up the whole case for them. So again, it's important to know the legal standard and then what things you should be thinking about if you're going to weigh in on that. Similarly, financial capacity is really similar but somewhat different construct, and gets into even just day-to-day financial management. So someone's ability to manage their own personal affairs, and the relevant constructs here that are important to be assessing or thinking about are their vulnerability, whether they are physically isolated, socially isolated, have depression or cognitive impairments that increase their vulnerability to undue influence or financial exploitation. And this too is something that providers are sometimes pulled into if there are disputes or adult protective service investigations that are ongoing. And I have seen a number of cases where primary care providers have been asked to weigh in on susceptibility to undue influence, even though it's not an expertise area for them. And some uncomfortable depositions where they've gone through the criteria for undue influence or some of the red flags, and providers say, yeah, I guess that was happening, but I really hadn't thought about it. So I just wanted to spend 2 minutes on that. Things that you may pay attention to in the office setting. So undue influence is really, the bottom line is the will of somebody else who overpowers the will of the person who is being influenced. And typically that person's in a very close confidential relationship, and they are exerting persuasion, deception. It's not overt, it's not coercion necessarily, it's very subtle. But the big red flags are somebody who is increasingly isolated while there's this other person that's kind of increasingly involved, coming to healthcare appointments or bank transactions, or all of a sudden there's a new financial planner, and then a poisoning of the well of other trusted either family members or longtime providers. There are other things to look at, things like in the financial realm, somebody's homebound, but all of a sudden there are all these ATM withdrawals. That doesn't make sense. So you can think of maybe some similar things in the healthcare realm. And not that because these things are happening, they are being unduly influenced, but they are things that should raise your suspicions and you maybe want to think about and assess. Where we probably should spend the most time is around medical decision making. And there's a landmark paper by Applebaum and Grissom from 2007 in the New England Journal of Medicine. And the main 4 components for this are communicating a consistent choice. So it's the same answer to the same question, ideally over time. And you could think about that as within a visit, at the beginning of a visit, the end of a visit, across visits, maybe reassessing things on annual or every 6 months. Understanding of the relevant information. So paraphrasing the pertinent medical facts. It doesn't have to be a verbatim understanding of the most complex nuances. Although as the decision becomes more complex and the stakes get higher, greater understanding and greater content is important. And then being able to sort those facts into how they apply to the individual. So one situation, what are the pros and cons? So if you're offering somebody 2 different treatments or treatment, not treatment, their ability to say, oh, okay, well, if I do this, that's going to impact my health this way, and the side effects and the risks are that. But if I do this, then the benefits may be that, and the cons may be that. And then their ability to communicate their reasoning or their rationale of how they have manipulated that information. And it's defensible. You may disagree with it. The family may disagree with it. But if it is in keeping with their values, or, they've applied all the right information and they're coming up with an answer that's maybe not in their best interest. If they can do that and it's consistent over time, ideally, then they would meet criteria as having capacity. So you can already see here, executive functioning is a huge cognitive construct as we think about the cognitive underpinnings of capacity. What does it look like in terms of prevalence of lack of capacity in select populations? So if we look at, and this is from JAMA way back in 2011, so healthy older adults, about 2.8% lack capacity. And these are structured capacity evaluation interviews. And we'll talk a little bit more about what those look like. In MCI, that percentage goes up to 20%. And those with at least mild Alzheimer's disease, it doubles again at about 54%. Lots, half or maybe more than half of people with dementia, thereby half capacity. So important to think about that too. So to that point, there were a couple of well-done studies looking at people with at least mild dementia, and the 48 that were interviewed, there were highly variable degrees of medical decision-making capacity, but about 40% were considered to have capacity. And those individuals that were also tended to have greater awareness of symptoms. They understood where they were in the course of the disease. They understood the diagnosis. And the findings from this, they used the mini-mental. It's really only helpful if it's less than 19, you're pretty sure that somebody's going to lack medical decision-making capacity, even for simple decisions. If it's greater than 23, they likely have capacity, but that's not perfect either. I would not use that as a cutoff and the only cutoff. Certainly other conversations and questions to ask there. How well do physicians and other healthcare providers do recognizing impaired medical decision-making capacity? And this is another JAMA study from 2011. About 42% of patients lacking capacity were recognized by physicians, and when they did recognize it, they were usually correct. And then on a medical inpatient ward, this was a research study, so these were researchers that went around and did comprehensive capacity interviews and evaluations. Almost half were found to lack capacity, but only a quarter were identified by the treatment team. So again, it's under-recognized. And I think there are a variety of reasons for that. One is this is messy and complicated, and wanting to preserve someone's autonomy and the presumption of capacity. So if we shift a little bit to evaluations, the main thing I think that's so important to think about is that ideally it's contemporaneous. So if there's a decision that needs to be made, whether it's a treatment decision or maybe somebody who wants to change their will or is going to make a big financial decision, the evaluation should happen as close to that decision as possible. And the evaluator needs to be aware of the basic contextual variables around, what are the laws, what are the relevant, RCWs and laws, what are the relevant clinical conditions, what are the relevant either psychiatric or cognitive underpinnings of this decision. If there are functional deficits like sensory issues or language even, making sure that those are addressed. And then ideally, these are prospective versus after the fact. I'll say a little bit more about that at the end, and the American Psychological Association and American Bar Association put together a very, very thorough handbook and overview of assessing capacity in older adults back in 2008. And their framework is, these are the things that you need to know if you're going to do these kinds of evaluations. These are also the things that you should keep in mind if you're going to weigh in on whether or not somebody has capacity. So again, the legal standard, what are the diagnoses, cognitive and otherwise, what are the risk considerations? You don't need to go through a detailed assessment of how you've ruled out undue influence, but boy, a comment that you've thought about that and it seems as though this person is well cared for and trusts their family. Any steps to enhance capacity, and sometimes the best decision is let's if it's not an urgent life-threatening, let's maybe delay this and see if we can enhance capacity by treating medical or psychiatric or other underlying issues that would undermine capacity, and then rendering ultimately your clinical judgment based on this. If we think about the cognitive domains that go into it, there are so many. I mean, certainly attention, comprehension, language abilities. I would argue that, expressive speech difficulties, especially if somebody can write or can express preferences or choices, either verbally or non-verbally or through pointing or other kind of means, maybe those are less important than comprehension difficulties, being able to understand the concepts. But I would say, reasoning and so executive functioning, inhibition, able to update information as new information comes in, all the things the frontal lobes do, those are so important. Memory is an interesting one, and when you think about financial capacity for somebody, say, whose estate has been stable for a very long time and there's no, moving pieces, short-term memory is, maybe not the most important construct if they want to make some different decisions. And then, of course, that idea of right to folly versus impairment. We don't have to agree with these decisions. We don't have to like them. Family doesn't have to like them. But if somebody can do those kind of steps that we've talked about, then they have the right to make those choices. That gets really tricky, but important to think about that. Some tools. So a lot of these are, especially in the medical decision-making realm, but also financial, they are kind of vignette structured. So I'm going to give you a hypothetical scenario. Tell me back, kind of what the pertinent points are. So you're assessing memory a little bit there. What are the pros and cons of each of the treatments? So that's a little bit of how the Hopemont works in Marston's instruments. But also this piece of, who do you want to have make decisions with you? What's important to you? All the other kind of contextual things that drive decision making. There's some nice ways to blend those in and account for those, in addition to cognitive impairments or maybe psychiatric conditions. The testament capacity tool and the financial decision-making tools become a lot more complex. And they're even, from simple monetary constructs of what are these coins to what are your assets? Is there anybody that you don't trust with your finances? Lots of very structured ways to assess those. What happens at the end of that? Boy, and again, this is where, we talk about, or we think about these outcomes as impacting people's rights. So the loss of rights of a guardian may be appointed. There may be enacting of a healthcare proxy or a durable power of attorney. There may be a representative payee. And then, of course, always thinking about ways to enhance capacity. So, which we've talked about a little bit. Just a word about retrospective evaluations. Boy, this is about the thinnest branch that I would ever go out on, because you are relying on the records, both medical, legal, and otherwise, after someone is deceased. And in Washington, we have a very, very low threshold for presumed capacity. So if somebody has fluctuating cognitive status, it is presumed that they were at their cognitive peak when any decision was made, unless there's really good evidence otherwise. And this is where, boy, it would have been lovely if this person had had a MOCA at least, or some kind of an opinion by a primary or other care provider around the time some decision needed to be made. And then otherwise you're relying on secondary documents, collateral interviews. So actionable steps for providers. What could you do today? Absolutely identifying and documenting cognitive impairment early. It is tempting to presume someone has capacity unless you have strong suspicions otherwise. I would argue that that's probably not the right approach. Ideally, documenting preferences early and reviewing those regularly, making sure that we are aware of who could help make decisions if capacity was suddenly lost, and making sure that you can contact them and maybe having that documented as well. And then, of course, all the things we've heard from Barack about the importance of early advanced care planning and regular review. The earlier these things are documented, both from a cognitive standpoint of trusting that the person has capacity to make these decisions, but also has the cognitive ability to think through and kind of reason, if this then that, if this then that. That's hard to do even in MCI sometimes, especially for complex and emotional decisions. Sometimes these are very much so. So I would say, document is the ideal. Resources. There are neuropsychologists in the community that do capacity evaluations. There are some assessment services like the GRAPT, designated mental health providers, Harborview, UW, neuropsych services. Our geriatric psychiatrists, both Dr. Carlson, who has done a great didactic here, and then Dr. Sean Demers, both do some capacity work. The link to the Advanced Directive for Dementia, if that hasn't fallen off your radar, And there's some limited resources through DSHS and the Alzheimer's Association as well. And Mimi, what do you think? I want to be mindful of the time. I do have a case. It's 12:40.
I would encourage you to go ahead.
Well, I will take that encouragement and go for it here. I'll try to be brief here too. So this is about a year ago. Let's see. So this was an 85-year-old male referred for capacity evaluation, secondary to concerns about impaired decision-making due to cognitive impairment. So the very first thing you have to do is clarify the referral. And my question to the primary care provider was, is this a medical decision-making capacity, financial, testamentary? And she said, yes. All those things, which we whittled down to medical decision-making and testamentary capacity because he wanted to make a change to his will. He had initially been seen about a year prior with a 2-year history of memory loss, some trouble with spelling, insidious onset, gradual progression, no fluctuations. He'd also been spending a lot more money, including on supplements and some donations to organizations that weren't totally in line with his values. A year after that, time I saw him, had word finding problems, was having much more trouble remembering, recent TV shows, movies, despite being interested. He was irritable, frustrated, physically aggressive in terms of some banging things around in the house, not assaultive, but out of character. No real change in his ideals, although the impulsive spending was getting there. Really fairly benign medical history, so remote history of AFib and TIA, both resolved without any kind of need for treatment. He had a CT in 2021 that showed some right greater than left temporal lobe atrophy and some generalized volume loss. His neurologist had started him on Aricept. He's up to 10 milligrams, no benefits. He's on 13 vitamins and supplements. Family history, self-reported as highly positive for Alzheimer's disease, although the quality of those diagnoses is unclear. No tobacco, alcohol, 16 years of education, bright guy, worked in finance, and was very physically active. History of recent marital therapy, partially around the spending and his agitation and slamming things around in the house. Agitated, friends were distancing themselves, financial stress, all over the place emotionally throughout the interview. Also very irritable when redirected and slammed the table a few times while being redirected and then corrected by his wife. And then during testing when redirected by the psychometrist. He had a prior neuropsych eval. I'm not going to go through this in detail, but I'll say, and this was a year before I saw him, he had some changes in language relative to his premorbid abilities and some executive functioning changes and a little bit of decreased capture, but relatively intact delayed memory. I do not do a comprehensive neuropsychological evaluation as part of capacity evaluations. You don't really need to, but you do need to screen. It's kind of like you need something more than a MOCA and something less than a neuropsych eval. So there's a targeted battery that I usually use that looks at executive functioning, language, and memory most heavily, screens for attention and some of the other related constructs. And he's had declines in executive functioning, language, and verbal memory, mostly around capturing information, but what gets in stays in. So a very frontal looking picture. And my impression was that this looked like FTD, not classic AD, could be frontal variant AD. Recommendations were FDG PET, med review with all the supplements, driving eval. He had a PET, not consistent with AD, reduced perfusion of the frontal and temporal lobes, typical of FDD and or depression. And we know he's not depressed. So when we think about capacity recommendations, and these are long, and they're long because, again, you're dealing with someone's rights. And basically, he had a score on the testamentary capacity assessment tool that was below the established cutoff. He had decent awareness of his basic finances, but he could not kind of assess risks and pros and cons of financial transactions. He had trouble kind of remembering what his assets were, and he could not really do much in the way of, okay, well, if you do this financially, then what would the outcome be? Especially as things became more complex. his score on the Lichtenberg was a 0. He had basically handed most of the financial things over to his wife at that point. So the idea was that he lacks capacity to make complex financial decisions. For medical treatment, we did the assessment of capacity to consent treatment interview, low to variable awareness of his medical conditions, poor insight into cognitive functioning, unable to identify medications or supplements or purposes. He did not know he was on Aricept still. Give him a brief hypothetical vignette about a possible medical condition and treatments, and he could remember a little bit about it right afterwards. And we're really not able to identify risks and benefits. So the upshot of that was, and I usually frame this in what sounds like a medical legal context of, on a more probable than not basis. He does not possess testamentary capacity, decision-making capacity, or capacity for more complex financial decisions. And given the nature of this diagnosis, more likely than not to be permanent and progressive, and similar for complex medical decisions. So AI capable of comprehending and participating in shared decision-making around relatively simple or concrete issues. Impairments in executive functioning and memory would undermine more complex medical decisions. Lack of insight and awareness deficits indicate ongoing need for assistance managing his medications. And then, of course, you have to indicate that just because he lacks capacity in these areas, that does not mean he lacks capacity in other areas. Or just because he lacks it now, maybe there are some things that one could do to enhance that capacity. It didn't seem like it in this case, but things to think about. So I will stop there. The only other thing I wanted to mention, I just also about 2-3 months ago did a financial capacity evaluation, and I think it's sometimes a little frustrating for providers and attorneys sometimes too, in that the outcome of this particular case was that the gentleman had capacity to create his will. He had a good understanding of his assets, who would benefit from those, but he did not have capacity to determine or name the trustee of that estate. He had a number of family issues that were going on, and some of his kids were more likely to have been exerting undue influence. And so that was again, it's not an all or nothing. And sometimes those yes for this, but no for that can be a little challenging. But I will stop there. And I knew Barack was going to have questions. I knew it.
Thank you so much, Chris.
Yeah, my pleasure.
That was great. Barack.
Yeah, and you kind of answered the question I had when you gave the final follow-up there at the end, which is just like, oh my goodness, like what a complicated mess his family and friends and lawyer are in terms of trying to sort of figure out what he is able to do and what he's not able to do. And so I mean, I was going to ask that, and then you said that, oh my God, it's really, really complicated and, step by step, really hard to figure out.
It is, and it's not an easy process in the sense that you're trying to weigh so many factors about, again, autonomy and ability, and then assessing, how do these certain things pertain to very specific kinds of decisions. But I think that's just the nature of this issue.
Right, and I think just, the other real important take home is just how there's just so much subjectivity to this, no matter how you slice it and dice it. I mean, so much of it is about just like your kind of like gut sense of, what are people's intentions and are they good or are they bad? And that's just so hard.
Yeah, that's not always knowable, right? I mean, sometimes, in the most overt cases, it's clear, but those are the ones that you don't usually get asked to assess because it's clear, right? But yeah. I think Carrie was next.
Okay.
Yeah, thanks, Chris. What a such an important topic. And I have a kind of a hard question, which is, we have a range of people on this call, from PCPs to specialists in different areas, but we are, all of us, are asked to weigh in about this, not uncommonly. And the access to a neuropsychologist like you is incredibly difficult. And I see Emma shaking her head because I know, like, we have one situation that we had in common, but you know, is there a 2.0 from your talk here to best train family doctors, you know, neurologists, specialists? Are there templates? Are there, you know, tools? Or would you say, you know, that's not in your lane? Like, don't try to do that. And it's a tough question to answer because I think maybe some of us would be in a position to be trained to do this, and maybe others might not. But could you take a swing at answering my question?
Yeah, absolutely. You know, and I don't know that you need a neuropsychologist or geriatric psychiatrist to do this. It really depends on the decision. So, you know, I could imagine the analog that I'm thinking about is, you know, diagnosis of dementia in the primary care setting, right? There are a wide number of cases that a well-trained primary care provider is going to knock that out of the park. I think that is true for capacity assessment too. It requires a little bit of, you know, diving into some of those metrics and, you know, those kind of the four pieces of consistency and, you know, and then just addressing those. And, you know, I've been involved in legal cases where that was enough, you know, that the primary care provider did that. The decision was such that, yeah, that worked. But I think it needs to be more than just yeah, I think this person has capacity, you know, or no, I don't think they do, because they've got a 23 on the MoCA. That's not enough. But I think knowing kind of what you need to address and then how you do that, that wouldn't take a lot of training for a lot of the decisions. But for others or for certain cases, then yeah, that's maybe where you need, you know, somebody to do a deeper dive. The other thing I will say is, you know, since these aren't neuropsych evals proper, these usually take me about 2 hours. And, you know, most of that is the interview. Maybe half hour, 40 minutes is cognitive testing. So, you know, and these are such kind of contemporary, maybe I'm going to regret saying this, but these are such, you know, pertinent and pressing issues that I work these in, you know, as soon as possible, because it's not the standard, you know, neuropsych eval that, you know, is booked out for 6 months. Let's see. I don't know who or how. I want to be respectful of time here too.
Yes, I think let's just do 2 more quick questions and then we need to move forward. So Erica.
Oh, thank you. So, Kristoffer, a question about when a primary care doctor is also, I struggle with this because as a social service provider, I'm having these conversations with the families and the residents themselves, and the residents who are getting, you know, paranoid, not wanting the families to be involved because they're just like, you know, stay out of my business. So they don't know when to jump in to get involved in my chart or how to actually start stepping into these conversations with the primary care doctors. And the doctors are not being solicitous as to, like, you know, we need, you know, I need your input too to triangulate this information. Also, there's some things, even people who don't have you know, memory issues will come away with not understanding what their diagnosis is. I had 3 cases of residents with CHF who did not know that was not a terminal illness, and 3 people who came to me to talk about end of life issues. They wanted to talk about end of life, and I was like, you guys, this is not an end of life issue. This is manageable. You need to talk to your doctors about this. And they had no idea. They thought they had to talk about wrapping up their business, about end of life. And so I think better education from the primary care doctors about what all of this means for whatever stage people are in, but how to actually get access to the doctors by, you know, the social workers and the, you know, when we can get in and talk to these people to triangulate the information that they're getting from the person with the memory loss is really hard to do.
Yeah, it is, right? And who does that, right? So that is one of the core things about capacity, is that ability to summarize the relevant facts of either a healthcare condition or a decision, you know, and that sometimes that requires repeated conversations. Sometimes that requires different types of, you know, kind of administration. So yeah, very, very hard. And then, yeah, it doesn't need to be a doctor. Is it a nurse case manager? Can it be a social worker? Can it be, you know, good questions.
Yes, thank you. Okay, Emma, quickly.
Yes. Hi, Chris. I'm wondering, is it a requirement for lawyers to ascertain medical documentation for patients who want to change their power of attorney? Because Kim's my social worker who's on the call, had a recent case where our patient saw me for cognitive impairment. She was functioning fairly well, but there was clear cognitive impairment, and she actually changed her power of attorney to her realtor, who she just started working with, both financial and medical. And so I'm just wondering, are there regulations around that? Like if they looked at our medical documentation, they would have known that maybe we need to hold off on changing this power of attorney. I referred her for neuropsych, of course, but I'm just wondering if you know of any. Surely they have to look at medical documentation to do that, right?
I am right in the middle of a case where you're reading my mail. So I'm not going to say a ton about that, but I'll get back to you. But I would say in general, they should, and especially estate planning attorneys have requirements of assessing undue influence and capacity to make decisions. How they do that, however, I think is up for grabs. And as far as I know, I'd have to double check on this. There is no mandate that they have to look at medical records. It would be best practice to, but I don't think they have any kind of a legal mandate that they have to do that.
Yeah.
You can imagine getting into some hot water later on if you don't.
Yeah. Okay, thank you. And again, thank you, Chris. That was a great presentation and just information we all need. So I'm going to move us forward now and share my screen. And Nicole Kane has agreed to do our case presentation. So Nicole, I'm going to go ahead and turn it over to you.
Thank you so much. I am so grateful to be able to talk about this client today. I've only been working with her and her family for about 5 months, but there's been a lot happening in a short amount of time and lots of layers to the situation. So I'll try and be concise, but I thought it would be helpful to just start out by framing it in terms of 2 main issues that have been difficult to navigate. One being how you think about sexual consent between 2 people with dementia. And then secondly, just management of some increasingly complex behaviors related to dementia. So my client is 84 years old. She's a retired social worker. She lives in assisted living for the past 3 years. Up until recently, her time there in assisted living has been going quite well. She moved there with her long-term partner. They've been together 20, 30 years. They reside in separate apartments because she has needs related to dementia and he has more physical needs related to some advanced health issues. Up until recently, despite them living separately, they would spend most of their day together. There's a private hired caregiver that would take them to meals together. They go to all the activities. They were both very engaged in the community there in assisted living. Right around, Mimi, I think you can advance the slide. Thank you. So right around January of this year, the client engaged in a relationship with another male resident in the building. The relationship was known to be sexual because the care staff witnessed sexual behavior. They'd go into the apartment to offer meds or do their scheduled check-ins, and they observed what was happening. The relationship between the 2 was described as fairly obsessive, where they would spend most of their time together in my client's apartment. They come out for meals, but other than that, were pretty much isolating themselves to the extent that my client was missing medications. I have little information about this other male resident because obviously he's not my client. There's only so much that could be shared with me. My understanding was that he also had some level of dementia and some behaviors associated with that. So what was happening is staff would go to my client's apartment to do their check-ins, offer medications. He would come to the door very angrily. He'd be verbally abusive to staff, also abusive to her family members who were trying to visit. And he would kind of raise his fist and yell and threaten, and basically staff just went away. The other thing that was noted was that there was a pretty dramatic change in my client's demeanor and behavior. Prior to that, like I was saying, she was highly social, engaged in the community and all the activities, had friends in the community, and staff and family both were reporting that she had very flat affect, was angry, kind of mimicking some of his behavior. Family would try to visit, she would tell them to go away, she'd hang up the phone, just very different. I tried to visit her. She came to the door with a very angry face, quickly slammed the door in my face, and this was not, to my knowledge, typical behavior. Mimi, you could advance the slide. So the daughter engaged our services in May. So that was, the sexual relationship started in January. So the relationship had been going on for a period of months. And the reasons she engaged us for help is like twofold. One, despite the concerns, the facility staff was repeatedly telling the family that their assessment of these two is that these are two consenting adults, and per resident rights, they had no ability to interfere in the relationship. So that was one piece. And, what the daughter said to me, she said, obviously this is a very yucky and uncomfortable situation, especially given the fact that my mom's long-term partner is completely aware of what's happening, which of course was very devastating for him. But at the same time, he was being very sympathetic and actually quite understanding of the situation. The daughter's position, she said, if my mom knows what she's doing and this is healthy for her, we've all decided we can look the other way, but this doesn't seem healthy for her. And I'm not quite sure she knows what she's doing. So, what am I missing here? The other piece, which was actually more concerning to her, was the dramatic change in her mom's mood and behavior. And then secondly, the fact that she was missing medications because of this male resident sort of gatekeeping at the apartment when staff would try to enter. The third issue was that a granddaughter had noticed what was described as a fairly big bruise on my client's breast that was suspicious, of course. This is not a person that falls or a person that bruises. It was reported to the facility. They attempted to look at it. The client would not allow them, and they just kind of let it go at that. So at the time that I met with the client's daughter, my initial recommendations, one, I felt like it needed to be reported to both RCS and APS. And I also recommended an evaluation from an outside provider. It did feel concerning to me that the facility did not think to have someone more specialized and someone more objective evaluate whether or not the client knew what she was doing, as especially because this is a facility that has a contracted psych practitioner involved, and they never thought to involve that person. Mimi, you can advance the slide. So I'll stop there. I'll say a little bit more about how that resolved to some extent and what's happening now. But here's some of this is spotty. I don't have lots of records, but this is what I know about her medical history. Apparently, the family started seeing cognitive symptoms as early as when she was in her late 60s. She wasn't formally diagnosed until 2018. She was diagnosed with Alzheimer's disease, and that was from a neurologist. Prior to that formal diagnosis, she did have an incident where she had fallen down the stairs. She didn't tell anybody, and it was a couple days later that she started to have some concerning symptoms. Family brought her to the emergency room, and it was determined that she had a brain bleed and had 2 surgeries. Again, I don't know any further details about that. And then outside of that, she just has, some cardiac history. Physically, she's in very good shape, very physically active, independent with all of her ADLs. She did have a MoCA score of 15 out of 30 in May. I don't have any records to show if there were any prior scores for comparison. Here's her medication list. I think all of these she's been on for a while, with the exception of the risperidone that was just added recently with some new behaviors that I'll talk about a little bit more. I don't have exact details, but my understanding is the risperidone was started about 3 or 4 weeks ago, started at 0.5 milligrams at bedtime. Behaviors were continuing to escalate. They increased it to 1 milligram. And then just a few days after that, added 0.5 in the morning. And that's due to some escalating behavior that I'll talk about. So she ended up being evaluated by 2 different psychiatrists. One was the one contracted with the facility, and then the family decided to engage a second person just to have a second opinion. Chris, I thought your discussion today on capacity was such a good tie-in, because it was fairly obvious to me in this process that it seemed like everyone was really kind of struggling knowing how to address sexual capacity to consent to a sexual relationship, and no one really wanted to do that. Even the 2 psychiatrists that evaluated her, there's nothing specific in the reports that really spoke to capacity for a sexual relationship, but what they both ended up saying was that they felt that the sexual relationship was harmful, and that she didn't appear to know, like she couldn't really identify who this person was or what she was doing. So both made the recommendation that the 2 should be separated. Obviously, that was not easy to do. So what ended up happening was the facility asked the family of the male resident to move him to a different location. So that happened. APS is still involved. It's an open case. Right after the male resident was relocated, my client never seemed to know that he had left. She never asked for him. There was no indication that she realized that there was like this big change. She immediately started seeking out her actual partner again. And it was almost hard to believe how dramatically she went back to her old self. It was like nothing ever happened. She started spending time with him again. They started going to activities. Everything was sort of back to normal, so to speak. That went on for probably a month or 2. And now what's happening is she's had a very significant change in her behavior. It was like so pronounced and dramatic that, of course, we're all suspicious that a UTI or something was going on, but medical workup, labs, UA, all of that has come back normal. What's happening, she's more confused. She's not remembering even her male partner anymore. She's asking for her deceased parents. She's packing her bags, trying to leave. She's had very kind of like frantic, what I would call kind of manic impulsive behavior. There was one episode where she was groping a male in the kind of public space of the assisted living community. There was another incident where she was in the dining room and she got irritated with another resident and pushed her. There was another kind of even more concerning incident where her granddaughter brought her to a dental appointment and she was getting pretty antsy, not wanting to be there. The granddaughter tried to redirect her. She punched the granddaughter, ran out of the dental clinic and ran all the way down I-90 until the police had to call her and, or they called the police and the police had to pick her up, bring her back to her assisted living community. And that's in the midst of those escalating behaviors happening, that's when the psychiatrist increased her risperidone. He acknowledged that it was sort of a more aggressive increase than he would have normally felt comfortable with. But the idea was that, we were concerned she was, like one more incident away from being sent out, potentially having a, geropsych stay. And that was obviously something we all wanted to avoid if possible. So she has been on that increase of risperidone for about a week now. The psychiatrist was worried she'd be sluggish. She's not. And some of the behaviors that I've been talking about, there haven't been any like huge outbursts, but still very complex behavior happening. Lots of irritability, just kind of frantic energy, still packing, trying to leave. So at this point, I mean, my questions for the group are a few things. One, had there been an opportunity to be involved right away in January when this sexual relationship first started, what would your recommendations be for what needed to happen at the outset? And any, I'm just curious about any other experience of, how you handle the issue of consent with, two people with dementia. And then secondly, any thoughts on how to handle her behavioral challenges? We are looking at alternative placement, but in the meantime, I'm fairly concerned that a hospitalization might happen, or, I'm honestly surprised she hasn't gotten kicked out of the assisted living community at this point. So I'm just curious about any ideas, anything that might have gotten missed.
Okay. Nicole, thank you. I am glad we have a full house for you today to help you with this incredibly complex case. So I'm good, and thank you for clarifying exactly what you hope for us to address. So with that, I'm going to stop sharing and open it up to the group for questions or comments or answers for Nicole. Erica.
Hey, Nikki. So, good to talk to you. I've had a situation like this before, and wondering about the other client in the relationship to what his level of equal mentation was, and if that was something that the community and their family, like there was ever a care conference or something that was brought about, if they had an equal mentation that they were both at, or if there was an obvious disequilibrium between the two of them. Because it sounded like he was very much the one in control, and maybe had a higher level, or she was just declining so rapidly.
Yeah, great question, Erica. I don't know a ton about him because of confidentiality. The facility was not able to tell me much about him because he's not my client. I learned a little bit more from the APS worker. She was a little bit more forthcoming in terms of what she could share, but still there was a lot that was held back. In the two families have never been in communication together. Like, the facility never facilitated communication between the two families. Is pretty tense, actually. My understanding is that he did have some level of cognitive issue. My guess was probably less than her. I mean, I know one example is that, in her assisted living community, she has a wander guard. She's not able to leave the building without somebody escorting her because she's unsafe. He did not. So that just tells me like maybe he had a little bit more ability if he could be safe out in the community and she couldn't. There was actually one episode where he took her out, despite her having a wander guard, he took her out of the building. They were gone for 3-4 hours until they were finally found and were escorted back to the building. So that's really all I know about him. I do know because, there was never any conclusion on like where the bruise came from. And my understanding was that criminal charges weren't going to be pressed and APS could not substantiate abuse of him or from him because he's also considered a vulnerable adult. Yeah. So that's all I know about him.
Thank you. Sylvia.
Yeah, so my question is more from my limited perspective as a neurologist. There's definitely way more to this than just neurology, but with the history of the dementia and the brain bleed, was an MRI ever repeated or a CT scan ever repeated to see if any changes were happening in the brain, especially as even when this other resident was moved, she continued to deteriorate, seemingly unrelated to that. And I'm just curious about that.
That's a great question. I don't know for sure. It's a good question for me to look into. My guess is she's probably not had a scan since 2018 when she had her diagnosis of Alzheimer's disease. And that's again, I've just known her for 5 months. That's what's really kept me on my toes is the just kind of rapidly changing behavior. It's just a little bit different than anything I've seen with past clients.
Yeah, so if this patient came to me, that's what I would think about. And I know being able to do an MRI at such a stage is probably near impossible, but a CT is pretty quick. And the other next step is if there is significantly more atrophy or even more, if there is more evidence of vascular disease or bleeding, maybe a short EEG might be worth it. In a person who's more functional, I think I'm repeating myself because there was a case similar to this last 2 weeks where I would put a 72-hour EEG on. That's in the off chance that she may be having frontal seizures, which can cause sudden change in behavior. Sometimes really unpredictable behavior because the frontal lobes are very complicated. This is delving into the rare issues, but if the question were posed to me, I would think that. And then I would also like to say that this is extremely complicated, and the way that you kind of went through with the process is unparalleled. At least in my area, there isn't a social worker that keeps, or a case manager that keeps following like this, and it typically falls on the primary doctor's lap or the neurologist's lap. So kudos for that.
Are frontal seizures something that could that be kind of a lingering effect from the brain bleed she had years ago, or that would connected perhaps?
Possibly. And the advanced dementia too is a big risk factor for seizures to happen. Yeah.
Thank you. It's helpful.
Okay, thank you, Sylvia, for your thoughts. Faye.
Hi, Nicole. I just want to say thank you for presenting. This is a amazing case. I was just wondering from the psychiatrists that were following the patient from a psychological standpoint, I'm just wondering, it's hard to know because, the patient is not able to express or even seem to remember all that has occurred, but there's obviously manifestations of potential, effects of what's happened. And from a psychological standpoint, it just makes me wonder if that's also potentially what we're seeing, things that she cannot get counseling for, any type of potential trauma she may have encountered or experienced during this this whole situation.
Thank you. I was wondering the same. I mean, I think everyone at this point agrees that this relationship that happened for 5-6 months was harmful in some way. And if that's contributing to the behavior that we're seeing and the decline cognitively.
Okay, thank you, Faye. Barack.
Yeah, like, oh my goodness, what a complicated, hard situation. And I would just like echo like the amazingly well way that you navigated this, and just really, really, really hard. And I think, I think in answer to like one of your questions about, like where to think about going from here, like, this is somebody who is like suffering from like really severe and very difficult to handle behavioral symptoms, so that the idea that she's going to be able to stay in an assisted living setting seems really, really low to me. And so I think that the sooner that the facility and the family are thinking about transferring to a higher level of care is like wise, because this is gonna end up in a sort of like crisis situation. It's just sort of heading in that direction in a very difficult to manage way. And so I think that would be one of my thoughts. And I'm also just like, in your answer to your question about like, well, looking back and sort of trying to suss out like, were all the right things done? Could it have been different? And I mean, this is just, it's just so hard, because like just sex makes everybody uncomfortable, right? I mean, it's just like, trying to sort of tell whether this is like healthy or unhealthy is like, I think, so hard, and trying to assess like, is there consent or not? And I mean, it's almost like a weird parallel to the conversation that we had way back when about like alcohol use, like how to determine whether, when it's like something which is like fun but can also be harmful, and how do you sort of like draw a line between what is like healthy use of alcohol or healthy sexual activity versus unhealthy use of alcohol or unhealthy sexual activity, and how do you determine when somebody has the capacity to make that decision? But then even then beyond that is like, okay, so maybe you've decided that somebody is not making good choices and doesn't have capacity to make good choices. How do you then kind of operationalize and keep them away from alcohol or keep them away from sexual activity, right? I mean, there's just, aside from the kind of abstract, there's like just the very practical sort of okay, what are we going to do? And so I mean, in this case, it's kind of like a miracle that the other male was sort of like moved to another facility. Like you could definitely imagine situations in this scenario where there would have been that conflict, because I mean, moving to a different place to live is a really disruptive thing to do. It's So you could definitely imagine where that other male would have been like, heck no, I'm not moving. Like, why doesn't she move? Like, why, like, and so so it just out of curiosity's sake, but it sounds like we don't know, like what kind of conversation was that with the male who moved away and with his family of like, where they were like, okay, yeah, we'll move. Okay. Like, because
Yeah, I don't think so. I think it was very hard and disruptive.
Yeah,
And the
like,
family was, it was tense. I don't,
yeah,
yeah, it was not well received, I think, because, at that time there was still a criminal investigation,
well,
in addition to
yeah,
the APS investigation. And I think because they were so
yeah,
heavily involved and fairly concerned, I
yeah,
think
yeah.
the family got pressured to just do it. Yeah.
Okay, thank you, Brock. I see Sylvia has another recommendation in the chat about testing for sexually transmitted diseases. So thank you, Sylvia. Yes. So we are approaching time, and Nicole, I just want to echo, thank you so much for presenting this case to us. Hope you found these comments useful, and you have also stimulated conversation among us about how common issues around sexuality are in dementia. And I think you can anticipate a didactic on this session sometime in the next few months to help us all. So again, thank you. And thank you for all the work and all the toil that you put into this case.
Thank you so much. Very appreciative.
Thank you. Okay, well, to wrap up here, our next session is Friday, October 13th, and Karen Hayes, a member of the Hub, will do a presentation on true life of a family caregiver. And I'm sure that will be fascinating and very informational for all of us. So with that, I would say thank you all for attending. Have a wonderful rest of the day and last day of summer. And tomorrow we welcome fall. So thank you all. And again, thank you, Nicole.
Thank you.